Hello and good evening, everyone. Welcome to our 20th Bluers Virtual Seminar. Bluers Virtual Seminar is a platform that allows health professionals to discuss current management updates of different health-related topics for better patient care. And this platform is brought to you by Ethiopia, a medical consultancy company founded by medical doctors and a computer engineer. I'm your host, Adem. I'm the co-founder and CTO at Ethiopia. And it's a huge pleasure for us to have Dr. Abdu Adem here with us to give us an update on the approach to oncology patients. And Dr. Abdu, to give you a little introduction about Dr. Abdu Adem, Dr. Abdu is an assistant professor of clinical oncology, and he has also an MPH. In addition to that, he's a certified LMG and quality improvement trainer, also ISUA fellow. In addition to that, Director Quality Improvement Clinical Governance for Quality Improvement Directorate at the St. Paul Millennium Hospital. He is also a head of oncology units, also at the St. Paul Millennium Hospital.
Thank you. Thank you very much for the nice introduction. So I'll be directly going into the today's session. So I'll be presenting about the brief epidemiology of cancer, and the main topic will be the approach to cancer patient. And so in today's session, we're going to see the epidemiology of cancer from the global and the Ethiopian perspective. And we'll also see the approach of patients and the management principle. And finally, as you said, we'll have a question and answer session. So as an objective of this session, I am expecting the attendees to understand the epidemiology of cancer from global and Ethiopian context, and to understand the general approach of cancer patients and the management principles, at least the basic management principle of the oncology patients. So to begin with, I hope everybody knows this picture of the cell cycle during our undergraduate medical school year in our histology lesson. But for those of you who are new for the medical field, this is a cycle which is called a cell cycle, in which our cells divide repeatedly when there is a need arises in our body. So most of the cells, they are in the G0 phase or in the arrest phase. But whenever there is a need arises, they will go through this a series of cycles. That's why the name is given as a cell cycle, and it has around 3 or 4 group cycles. But the most important component of the cell cycle is the S phase or the synthesis phase, as you know, because it is very sensitive, and one cell is divided into 2, and each chromosome of the 46 chromosome is divided into 23 chromosomes. So this is the phase of the cell cycle, which is very, very prone to any damage. And whenever there is a damage to this cycle of the cell cycle, there is a high chance of malignancy, and that's why I brought this picture into your attention. And as you remember, the cancer is not a single disease, it's a group of disease that can arise from any part of our body. And it is when our normal cells proliferate uncontrollably, and they result from the defective cell cycle controlling mechanism and the spread of abnormal cell. So whenever there is a mutation in our tumor suppressor gene, as you know, our body is having a lot of tumor and suppressor genes naturally, because our bodies are, they are prone to develop cancer or tumor. So by nature or naturally, we don't have these tumor suppressor genes. Many of them, there are a lot of tumor suppressor genes. For example, one of them is P53, or which is called the guardian of the cell. So whenever there is a mutation or whenever there is a damage to such kind of tumor suppressor gene, there is no way that our body controls the proliferation of cells. So they proliferate uncontrollably in a way that they produce huge amount of, and they consume huge amount of our body's nutrients. So the DNA, the repair genes also deactivate us, and the proto-oncogenes, which are the oncogenes that create us, and the actual cancer will be activated, and finally a cancer will be developed. So we can say that cancer is generally a genetic disease. Whatever is the cause might be environmental, or it might be inherited genetic cause, but at the end of the day, the problem creates a genetic problem, and that results in the uncontrolled proliferation of our normal cells. That's why we said cancer is a genetic problem, or it is a genetic disease. So when you see the cause of the cancer, that means which causes the damage or the mutation in the, or that inactivates the tumor suppressor gene. Usually it's not completely understood, but there are factors which increase the risk, or they may act or simultaneously or in sequence. And some of them they can initiate, and some of them they promote the growth of the cancer cell. So we divide them into two broad categories. One of them is potentially modifiable risk factors. In this group of risk factors included like tobacco, excess body weight, alcohol use, and so on. Generally, these are modifiable risk factors. So by modifying most of such kind of risk factor, we can decrease the risk of having cancer. And the non-modifiable risk factors included in this group are the inherited genetic mutations. So cancer can also be inherited from our families, from our close families, like our mothers, like our sisters, our fathers, and so on. So cancer can also be inherited, and in such cases, the risk factor is non-modifiable. There is no way that we can modify the risk factor. And when we see the risk factor of cancer, most of the risk factors are potentially modifiable. And one report from WHO says that around 2/3 of, or 60% of the risk factor for cancer are modifiable. So we have to differentiate cancer or malignant tumor from any tumor. So the thing that I observed during my clinical practice is that patients are not told the exact diagnosis of their disease, rather they are told to have a tumor. And tumor doesn't mean that a cancer. As I told you, cancer should be defined as it's a group of disease which is characterized by uncontrolled cell proliferation. But a tumor can be malignant or it can be benign. So whenever you say cancer, it is not a benign disease, it is a malignant tumor. And also, I hope you remember this picture of hallmarks of cancer. When a cell having the damage in the tumor suppressor gene, they will have, or they will attain different hallmarks or characteristic of cancer. For example, a cancer which is changed, or a cell which is changed into cancer will have a sustainable proliferative signaling without any external effect, and they will also evade the growth suppressor, and they don't need any replicative induction from any external thing, and they are also having activating invasion and metastatic capabilities. That's why most of the cancer or malignant tumors, they invade the neighboring structures and different distant structures, because they actually have the capacity to activate the invasion and metastatic capability during the process of the carcinogenesis. And also during the molecular changes of the cancers that I showed you before, they induced also angiogenesis, because they proliferate uncontrollably. So they need a huge amount of nutrition. So for that, they need a huge amount of angiogenesis formation or blood vessel formation. And that's why most of the tumor cell or the cancer cells, they bleed easily, and it is very difficult to control the bleeding from the cancer. And it's advisable not to touch the cancer like by giving wound care, because of this fact, because of they have a huge amount of blood vessels in their body. And as you can see, they induce angiogenesis, so they acquire more capacity to collect the nutrients from the body. So the patients, most of the patients, cancer patients, they are malnourished, because the cancer cells, they are dependent on the nutrition of the patient. So they take and they share most of the shares of the nutrition from the patient are taken by the cancer cells. That's why most of the patients, cancer patients, are nutritionally malnourished, and they need malnutrition or treatment of the nutrition status. And finally, the cancer cell that has all these capabilities will be resistant to death or apoptosis. So the cancer cells, finally, they will be resistant to death, and they will be immortal. And that's why we have a lot of cells in our body, and that can be expressed as a mass. So what's the importance of understanding this hallmark of cancer? So as you can see from this picture, understanding this hallmark of cancer is very essential in developing targeted therapies. As you know, nowadays in the Western countries, in the developed countries, cancer is considered as a chronic illness, not something that's not curable. It's because they understand the molecular biogenesis and the underlying molecular alterations of cancer, and they can prepare different targeted therapies that can target the different molecular alterations and the hallmarks of cancer, and they can target the cancer at different stages. So they can cure the cancer easily. So what they worried right now is not about curing the cancer, rather what they worried in the first world or in the European countries or in the developed countries is about the survival of the cancer survivors. Rather, they cure the cancer easily, but they are worried about the complications from the cancer, because treating cancer or curing cancer has its own complications like infertility, secondary malignancy, and so on. So this is the importance of understanding the hallmarks of cancer and the molecular basics of cancer. So saying this, when I come to the main topic of cancer epidemiology at global level. So as you can see from the slide, this is a report, the latest report from the WHO cancer unit. And in 2021, around 19.3 million new cases of cancer were registered around the world. And the top 3 malignancies, both in male and female, were breast, lung, and colorectal cancer, almost accounting for around 30% of all, 1/3 of the malignancies. But when you see the mortality-wise or as a cause of cancer, still lung cancer is the leading cause of cancer in both sexes. But when we see the mortality rate as compared to the incidence rate of cancer, as you can see from the slide, still having all these developments in the treatment of cancer half of the cancer patients, the newly diagnosed patients, will be dead because of the cancer. So still cancer is the second leading mortality and morbidity globally, next to cardiovascular disease at the moment. When you see in males, there is a slight male predominance of cancer, both in the mortality and in the incidence. As you can see from the picture, lung cancer, prostate cancer, and colorectal cancer are the three most common cancer in male. Previously, it was prostate cancer, which was the leading cause of in the newly diagnosed cancer in male, but nowadays, because of the increased incidence of smoking, both in male and female, lung cancer is becoming the predominant type of cancer in male. And when we see the case of females globally, as you can see, there is a slight decrement of cancer incidence in female as compared to those in male. The predominant type of cancer occurring in female globally is breast cancer, which is responsible around for one-fourth of the incidence rate, and it is also responsible for around 15% of the diseases of cancer-related diseases in women. This is the data that we have from WHO at the moment, or in the latest data in 2020. So having the increment in the burden and in the trend of cancer patients, the WHO and the ASCO, the American Society of Cancer, they predicted the cancer epidemiology in 2014. That means after 18 years. So they predicted that after 18 years or after 20 years, the global epidemiology of cancer will be changed, and the most predominant cause of death and morbidity will be cancer preceding or surpassing cardiovascular illness. So as you can see in 2040, cancer will be the newly diagnosed cancer will be like 28 million cases per year, and the highest increment will be in those countries we're having low and middle income countries, both in mortality and morbidity. So the incidence of cancer will be almost plateau in those countries having high income countries, but in the countries with low and middle income countries, the burden will be increasing up to 95% of the time. This is the reason they mentioned is that there is a growth in the aging population, and there is also a growth in the population size itself. So, for example, if we take the growth of our population, it is 2.5% per year, the population growth, and the aging, the life expectancy is around 60 years and 59 years. For female and males respectively in Ethiopia. So as the years go on, the aging population is increasing, and as the aging population increases, the chance of having cancer also increases. However, they also stated that even if they estimated after 20 years, the cancer will be the leading cause of mortality and morbidity, and we'll have like 28 million new cases of cancer. This can also be an underestimation of the old cases, given that there is an wide adoption of unhealthy behaviors of lifestyle as associated with globalization and urbanization. So, as you know, we are adopting the Western lifestyle modification and lifestyle and their behaviors without any modification like smoking, alcohol intake, physical inactivity, and there is also a huge change in the reproductive patterns like declining fertility rate, late age at first, childbirth, and so on. These all are modifiable risk factors, but we are adopting from the Western countries, and this will increase even further from the predicted cancer epidemiology by 2040. When we come to the cancer epidemiology in our country, there is a huge gap in our country epidemiology because all the data that we have so far is underestimation of the real cancer burden in the ground because we don't have a nationwide cancer registry. In the Western world, every cancer case will be registered. They analyze the cases every 3 months, every 6 months, every year, and they publish the data and they know the trends and so on. But we don't have such kind of cancer registry nationwide. The one that is available is in Black Lion Hospital, which is Addis Ababa Cancer Registry. And the limitation of this cancer registry is that it only considers patients from Addis Ababa alone. So it doesn't reflect the whole country's epidemiology of cancer. There is one paper which was established in Journal of Global Oncology in 2018. So they estimated the incidence of cancer and they included the data from the Tukurambasa Hospital Oncology Department and some 6 periphery cancer centers in the country. And they estimated the incidence and they found that around 70,000 cases per year will be diagnosed in 2015. But I don't think this is the real data that we are facing. As I told you, there is a huge underestimation of the cancer epidemiology in our country. And this paper also shows that leukemia was the leading cause of diagnosis in pediatric age group. But when we come to the woman, as you can see from the picture, breast cancer, cervical, and ovarian cancer are the predominant or the leading cause of cancer, the top 3 cancers in females, while colorectal cancer, non-Hodgkin's lymphoma, and prostate cancer are the top 3 cancers in women, in male. There is also another paper which was published in PLOS in 2011. So as you can see, there was an evaluation of the number of patients visited the Tukurambasa Radiotherapy Oncology Center from the year of 1997 up to 2011. Almost it is like around 12 years data. So as you can see, there is an increasing pattern or an increasing trend of cancer in our country, and most of around 2/3 of or 3/4 of the cancer patients, they present at a stage of 3 or 4. So that is in clear contrast of the epidemiology of cancer in Western countries, where around 80 to 85% of the cases present at stage 1 or 2. But in our country, the reverse is true. Most of the patients, around 70%, they present around stage 3 or stage 4. That means there is nothing that we can do except palliation and palliative care. So having said this, let me give you a sample case and just take 5 minutes to think about the case, and we'll continue on the approach of the case. So let's say this is one of the cases that I have seen in my clinic. She's a 37-year-old female, para-1 housewife, and she's premenopausal. She presented with left breast lump of 1 year, and she has also productive cough of blood tingled sputum. She visited the health center many times and she was treated with different antibiotics, but she didn't had any improvement with the antibiotics. She was also visiting the holy water so many times. So finally, she presented to us with this presentation. So the question is, how do you approach this patient? If you are the first physician or the health professional who is evaluating this patient, how do you approach this patient? So think about the case, and let me continue with the approach of the cancer patients, and you can relate the case with the discussion that I'm going to present from now on. And if you have any question on the sample case, you can ask me before proceeding to the approach of patients. Okay, shall I proceed? Okay.
Yeah. You can all write your questions even on this one also, on the question and answer, and you can answer it there, or you can read some of the chats from the chat box and can kind of communicate.
Okay, someone is answering like mammography, baseline investigation, FNA, chest CT for metastasis, chest X-ray, chest CT, and so on. Okay, history, physical examination could tell us more in addition to investigation. Okay, physical examination, FNA. So I'm receiving a lot of answers. So keep in your mind this case. And please think that you are the first physician or is a professional having just to evaluate this patient, and let's proceed to the evaluation of patients. So the first approach to the cancer patient should focus on the history, as most of you answered. So the history should focus on the demographic data. So you have to ask the patient their age, their living address, because these are all important for the treatment of the patient. As I will tell you later on how these are very important. The demography, the religion, the social thought, and so on. As we have seen, this patient, for example, she was visiting lots of health centers and holy waters that should be included in the demographic data. The presenting symptoms should be explained well, and we have to also examine the signs and symptoms of metastasis because breast cancer, as I told you, any cancer in our country, most of the patients, they present with stage 3 or stage 4 disease. So you have to ask the patient for the presence or absence of metastasis. And the most common signs for metastasis are the bone, the liver, the lung, and the brain. So you have to ask symptoms related to these organs. And you have to also assess the risk factor for patients. Usually the risk factor for breast cancer includes nulliparity, the first childbirth more than 30 years old, the use of OCP for more than 5 years, family history, and so on and so on. So you have to ask patient for such kind of risk factor, and the age at menarche is also very important, and the age at menopause is also important. So you have to include in the risk factor assessment in your history. And you have to ask also comorbidities, because these are very important for the selection of the drugs or the chemotherapy drugs. And you have to also assess the psychosocial assessment and support for the patient. For example, with whom the patient is living with. As I told you, this patient is a housewife. So assessing the patient for psychosocial support is very important, because once you start the treatment for cancer, the complication of the treatment, the complication of the disease, it needs so much support from their families and from their social. So you have to assess the patient in such a manner so that the history should include all these components. The other one approach component of the patient with cancer is physical examination. As usual, you have to take vital signs, every vital sign. But what is different from any other patient is we add the pain score as a fifth vital sign, because most of cancer patients, they do have pain. So we have to add pain score, and we have to take the weight, height, body surface area, and body mass index, because as I have told you earlier, most of the patients are malnourished. So you have to calculate the nutrition status of patients by measuring all these parameters, and you have to do old system-wise physical examination, and you have to measure exactly in centimeter the tumor, because it will help for the follow-up of the tumor while giving the treatment. So guessing the tumor size is not acceptable in oncology practice. You have to measure exactly using the centimeter, and you have to put the patient tumor in centimeter, and pain score, as I told you, and the performance status, as they're using the ECOG and Karnofsky score, has to be included in the physical examination. And today, in the era of technology, you don't have to calculate the body mass, the body surface area using, such complicated formula. And there are so many applications that you can use to calculate the body surface area, the body mass index. What you need is only the height and the weight of the patient. Otherwise, they will calculate and they will give you the co-performance status, the body surface area, and the body mass index, and even the category of the nutritional status. So, as I told you, pain is very, very important, and you have to assess pain using different tools. One of the tools is a visual pain assessment tool. So as you can see, it has 3 types of pain assessment parameters. One is in number. So as the number increases, the severity of the pain increases. And the other one is in color, which is in green, yellow, and red. And the other one is in facial expression. Usually this is used for pediatric age group patients. So pain is categorized as mild, moderate, and severe pain. So this category is very, very important because, as you know, the WHO pain ladder is dependent on the score of the pain. So you have to score the patient as 1 to 3, 4 to 6, and 7 up to 10 for mild, moderate, and severe pain, respectively. So, for example, if the patient is having a mild pain, the drugs that you use can be just simple non-steroidal or nanopoid analgesics. But for those patients having a mild to moderate pain, the tramadol-like and codeine or a weak opioid can be used in the management of the pain. But for patients having severe pain, without any hesitation, you have to use opioid drugs like morphine. So unless and otherwise you score the pain severity exactly, you can't manage the pain. So that's why you need to score the pain as one part of the physical examination. And the performance status, as I told you, we can use the ECOG or the WHO score system and the Karnofsky scale, but most of the time in the oncology practice, we use the ECOG performance status. So it will tell you how the patient is active, whether they are, take caring of themselves, and whether they are active or not. So based on the criteria that are defined here, you can give the patient this performance score, because this is also very important. For example, for those patients having a performance score of 3 or 4, you can't give any curative treatment, including chemotherapy, because it will worsen their condition. So chemotherapy, whether it is palliative or curative, should be given for those patients having performance status of 0 to 2. So that's why we need a performance status evaluation in every oncology patients. The other approach for cancer patient is investigation, as you said in most of the answer. So the routine investigation, including CBC, blood group, RH, because most of the patients, oncology patients, they will be anemic. So we should know their blood group in RH, and we should have also chemistry, viral markers, including hepatitis B and C. And also we don't have to forget to do urine HCG for those women in the reproductive age group, because if you are going to start chemotherapy, the woman should not be pregnant, especially in the first trimester, because chemotherapy is teratogenic. So pregnancy should not be, the obstacle for the treatment, and you have to make sure that the women are not pregnant. And if they are pregnant, you have to advise the patient, if it is in the early stage of pregnant, you have to advise them either to go for the treatment or for the medical abortion. And the other investigation is diagnostic investigation. This is diagnostic for the cancer itself. So we might use tumor markers for different types of cancer, but one thing that you have to know about tumor marker is one thing, they are non-specific, and it is impossible to diagnose cancer, except very few cancers, to diagnose a cancer based on only tumor marker. For example, in pancreatic cancer or pancreatic adenocarcinoma, it is very difficult to take samples. So in that case, based on the imaging and the tumor marker, you can establish the diagnosis. But in other accessible tumors, tumor markers are usually used for the treatment follow-up and assessment. The most important diagnostic tool or diagnosis investigation is pathology. So a pathology can be done by FNA, biopsy, corneal biopsy, incisional, excisional biopsy, endoscopic, colonoscopic, upper endoscopic biopsy. But you have to know that whenever there is access, you have to take adequate sample using the biopsy, whether corneal, incisional, or endoscopic biopsy. FNA, sometimes it misses a lot of cancer, including breast cancer and thyroid cancer. So it is advisable to have a biopsy, and hormonal analysis, for example, for breast cancer, for such kind of, for the cases that I presented earlier, can be done only from the biopsy specimen, not from the FNA specimen. So these are the diagnostic investigations that we can do for cancer patients. The other investigation tools that are used for cancer patients are used for staging. So as you know, for staging, we use, except hematologic malignancies, we use TNM staging method for the tumor, for the node, and for the metastasis. So for that, we use imaging modalities. In our country, usually we use chest X-ray, ultrasound, CT, MRI. But nowadays, the best modality to stage a patient is using a bone scan or PET scan. So PET-CT is the best modality to stage a patient. So when you have a PET scan, for example, if you see this picture, on the left side, this is a CT scan of a patient having right lower lobe resection for the diagnosis of non-small cell lung cancer on the left side. But on the right side, you can see scar or postoperative change from the active tumor. So this PET-CT or using 18 fluoride is a metabolic scan, and that clearly defines the extent of the tumor, because the tumor cells, they attract, because this 18 fluoride is attached to the glucose. And as I told you earlier, the tumor cells are having high metabolic rate, so they take this glucose, and they didn't know that whether the glucose is attached with this fluorine. So they take the glucose, and we scan the glucose, we scan the fluorine, the fluorine, the 18 fluorine, which is attached to the glucose. So if you have such kind of pictures in a cancer patient, definitely it is telling you that this is a malignancy. For example, in this patient is having pleura, liver, and some pedicular involvement from the lung. But it is very difficult to diagnose metastasis of the bone, metastasis of the liver sometimes. based on the CT scan alone. So this is very important, and currently it is, unfortunately, it is not available in our country, but in the near future, St. Paul Hospital will have a PET scan, and we're under constructing the setup for nuclear medicine and a PET scan. So I hope in the coming 2 years, we'll have a setup like this in our hospital. So these are some of the the staging modalities, at least as much as possible for patients with cancer. It's better to have CT scan, MRI, even in our country, because these are widely available. And other investigations that are very basic and very important are for those comorbidities. For example, for patients with DM, hypertension, RVI patients, we need to have the baseline investigations. For example, in RVI patients, we need the CD4 count, because for those patients with CD4 count of less than 200, we can't give chemotherapy, because chemotherapy will further worsen the CD4 count to a very low level. So such kind of baseline information are also important. So this is how we approach a cancer patient based on history, physical examination, targeted physical examination, and investigation-wise. And the other important thing that I think you have to know is the management principle. So you have to always consider the disease stage, whether the disease stage, because for example, if the cancer stage is 1 to 3, you can plan for curative treatment. But once the stage is a stage 4, the possibility of curing the patient is impossible. So the treatment aim is always palliative in stage 4 disease. So disease stage before managing the patient is very important. And that's why we have to stage the patient before any treatment. And the performance status, as I told you earlier, is also important. The social support, the pain scores, availability of drugs, and expertise is also very important, because if you order a drug which is not available, and if you tell them the patient some interventions for which the expertise is not available in our country, is sometimes traumatic for the patient. So you have to individualize the treatment of cancer patients based on the availability and the expertise. And you have to always also consider comorbidities. For example, for patients with cardiac illness, there are certain chemotherapeutic drugs which are cardiotoxic, and we have to avoid these drugs. Either we have to avoid them, or we have to follow the cardiac condition with frequent echocardiographic examination. So comorbidity evaluation, as I told you earlier, is also very, very important. So the options of management for cancer patients include surgery, chemotherapy, hormonal therapies, targeted treatments, palliative care and pain management, supportive care with best supportive care, nutrition, psychosocial, peer group discussion, health education, and so on. And all these modalities of treatment, they should also be given together or in different sequences, depending on the stage of the tumor. For example, if you have a patient with breast cancer in stage 3 or locally advanced breast cancer, you have to start with chemotherapy, and then after chemotherapy administration, you have to, based on the response of the tumor, you have to or operate the patient, or surgery should be done. Then post-operatively, hormonal therapies, targeted therapies, and other components of the therapy should be started. So it is from the very beginning that you have to plan for the management of the patient for the good outcome of the oncology patient. So one thing that I want to highlight for you is a component of palliative care. I want to tell you this because, in old medicine or in older days, palliative care was considered as a break of, the care that is given as the break of death. So it was neglected, and it is given, as you can see from the picture, at the end of the patient's life. but that is very, very dangerous, and it has a very missed opportunities for many, many years. So the current thought, or the new thought for medicine or palliative care, is that you have to start palliative care from the very diagnostic, from the very moment that you diagnose cancer. So as you can see from the picture, the portion of the palliative care, or the contribution of palliative care, increases as the time goes on. So the contribution of palliative care starts slowly or in a very small amount, and it increases to a larger proportion during the last hours of the patients. So palliative care should be started from the diagnosis, from the time when you diagnose cancer, and it has to continue even to the families, during their bereavement of their families or diseased patients. So these are the components of palliative care. We have to control symptoms effectively using the different modalities of pain control that I told you earlier, using the WHO ladder and so on. You have to control effectively the pain, rehabilitation. We have to make sure that we need to maximize the independence of the patient, because as we maximize the independence of the patient, the confidence of the patient and the adherence to the treatment as well will increase. So rehabilitation is also part of the palliative care. And the other treatment that's mentioned earlier, the management options like the surgery, chemotherapy, hormonal therapy, targeted in any other treatment that should be also included in the continuity of care, and there should be a coordination of treatment. So in these cases, a multidisciplinary team should be included in the management of cancer patients. And ideally, any cancer patient should be treated in a multidisciplinary team, so that different teams contribute to the different management options of cancer patients. And the other thing that we lack in most of the time is effective communication. And I heard a lot of patients that they had major surgery, but they don't know their disease condition or their cancer. So this is a pity that we have been facing. So patients, they need to be communicated about the disease condition, their prognosis, the treatment options, and so on. So this is a process of disclosure, and we have to adopt in our daily practice. And it has its own principle, disclosure. Probably in the next session, I might highlight you about disclosure, but it is part of the palliative care, and it has to be included in the palliative care package. And finally, there are some patients whom we can't cure, but we can provide, or we can continue our care even to the terminal level, and we have to support the families for their bereavement as well. So palliative care is not all about pain management. Rather, it should be started from the very time of the diagnosis, and it should come to end when the patient dies, and even it has to be continued until the bereavement process, and you have to also continue your care for the families, and you have to stimulate the patient families for screening and so on and so on. So this is the new thought of medicine about palliative care. So you have to think palliative care in such a way. It is not all about pain management. So in summary, cancer is an increasing public health problem globally and in our country as well. So approach and management to cancer patients should follow a comprehensive and multidisciplinary approach, as we have seen so far. So I think with this, here is my website, and you can have the details of my contacts, my phone number, my Telegram number, and so on. And you can also forward if you have any question via the email in which you can find in my website. Otherwise, this is what we have, what I have for today's session, and the stage is open for question and answer. And thank you for your attention.
Thank you so much, Doctor, for this amazing presentation. So participants who have questions, you can write your question in the question and answer, so Doctor will answer it.
Okay, there is a question. It says there is a saying, the only way to not to have cancer is not to be born. How do you see this? And what is the incidence of cancer? So my answer for the first part of the question is that partly it is correct and partly it's wrong. As I discussed earlier, the risk factors for cancers can be divided as modifiable and non-modifiable. Most of around 60% of the cancers are preventable by modifying the risk factors, like by cessation of smoking, by avoiding alcohol use, by living, a healthy living, and by doing physical activity, by having a proper weight, and so on and so on. But this is true only for around 60% of the cases. For the rest, for the 40% or 35% of the cases, the risk factors are genetics. And for the genetic causes, we can't do anything because the patient, the person is born with a genetic defect. So we can't say that there is a chance of we can say that there is a high chance of cancer, but we can't say that there is no definite risk of cancer in this patient. For example, patients who are born with BRCA1 or BRCA2 mutation, which are a tumor suppressor gene in women. So the chance of having breast cancer in these patients is around 80%. So around 20% of the cases, they will not have cancer, even though they have the genetic mutation. So, it's difficult to agree with the saying that the only solution not to have cancer is not to be born. Still, even though you are born with the genetic mutation, that doesn't mean that you are going to have the cancer. It will increase the risk, but that doesn't mean that exactly you will not have the cancer. So that's my answer. And the other part of the question was that with the incidence of cancer in normal person, what is the incidence of having a cancer during the lifetime? It is estimated that around 25% of the whole population. That means 1% in 4 out of 4 will have cancer. So every one of us, 1 in 4 will have a cancer. So that is the estimate given based on the current estimation. And the second question, a 60 years old patient diagnosed with stage 2B breast cancer after mastectomy, sentinel lymph node biopsy negative, HER2 negative, PRAR positive, has comorbidities like DM, RVI, and is currently on chemo. So would she require radiotherapy and hormonal therapy? So this patient, fortunately, her HER2 is negative because this is a poor prognostic sign. Sentinel lymph node biopsy is negative, but it is a stage 2B. And to decide on the radiotherapy requirement of this patient, we need to see the size of the tumor. If it is like more than 3 centimeters, automatically she needs radiotherapy. But if it is like between 2 and 5 centimeters, the T size, we need to see the grade. If it is like high grade tumor, we need to give radiotherapy. because the information that is given for this patient is inadequate. I only know the grade, I only know the stage 2B and the hormonal status and the lymph node status, but the lymphovascular status, the perineal status, the grade, all are important. The margin status are important to decide on the radiotherapy. But the fact that she is stage 2B is more likely to have a recurrence, so she needs radiotherapy, but we need to have the information like the lymphovascular, perineal, the margins, the grade, and so on. So if the patient is having like the tumor size more than 3 centimeters, more than 5 centimeters, high-grade tumor, the lymphovascular positive or perineal invasive, perineal invasion positive, even though the margin is negative, radiotherapy should be administered as an adjuvant treatment. And chemotherapy is actually automatic because any tumor with a size of more than 1 centimeter need chemotherapy. So she needs chemotherapy. And coming to the hormonal treatment, the fact that she's ARPR, after the radiotherapy and the chemotherapy, she needs hormonal therapy based on the age. Since this is a 60-year-old male patient, female patient, she's post-menopausal. The preferred treatment is aromatase inhibitors, but you can use also tamoxifen for 2-3 years, and then you can shift to aromatase inhibitors. In any case, she needs hormonal therapy, but she doesn't need any targeted treatment targeting the HER2 because HER2 is negative. And the next question is, what is the tumor marker can be used for pancreatic C? For pancreatic C, as I told you, the tumor marker is CA as 19-9. I'm writing on the screen. Cancer protein 19-9 is the tumor marker, which we are using for pancreatic C, but it is not only for pancreatic C, but it can be used for many other cancers in the hepatobiliary line. And we need a radiotherapy, a good radiotherapy correlation to diagnose pancreatic C. The other question from one of our participants is, during chemotherapy, what is the cutoff WBC count to continue with chemotherapy? The WBC count, usually what we use is the neutrophil count. So the absolute neutrophil count should be more than 1,500. So every cycle, when the patient comes, we do CBC, organ function test, and so on. So the hemoglobin should be more than 10. The platelet count should be more than 100,000, and the WBC count, specifically the neutrophil count, should be more than 1,500. Is there a place for folic acid supplementation for leukopenia during the chemo? Folic acid supplementation is part of the treatment in some of the treatment regimens. For example, for those patients having a colorectal cancer, we are supplementing folic acid along with 5-fluorouracil or pyrimidine based treatments. And like methotrexate, if you are treating the patients with methotrexate, folic acid supplementation has a role, but that is not for leukopenia during the treatment. For the leukopenia, you have to give GCSF or bone marrow stimulating agents. The other question is that in your current practice, how effective is chemotherapy? The effectiveness of chemotherapy is dependent on the type of the tumor, the stage of the tumor, the status of the patient, the type of the chemotherapy even that we use, and the regimen. And sometimes, the category 1 chemotherapy regimens may not be available in our setup, so we use second line, category 2, category 3 chemotherapy regimens and single agent chemotherapy regimens as well. So it depends on many factors. and we can't give a single answer for such kind of question, but it depends on the disease type, on the disease stage, on the patient condition, and the availability of the drug as well. One other question is asking about, tell us more about the PET scan. So PET scan, the main difference between PET scan and CT scan is PET scan is a molecular imaging, while CT scan or MRI is anatomic imaging, which they show you the anatomy, and radiologists they describe what they see on the anatomy, and they told you what their impression is. But in PET scan, you give the patient a pharmaceutical, a tagged pharmaceutical, for example. Most usually what we use is 18 fluorine. So this fluorine is tagged with glucose. And as I told you, the tumor cells are very hungry and they want the glucose, not the fluorine. So they took the glucose because they have a high metabolic rate. So during this metabolic rate, and when they took the glucose, we see the fluorine in those cancer cells taking that glucose. The normal cells, they have a normal amount of uptake of the fluorine 18. So it is calculated, and when there is a cancer, the uptake of the fluorine 18 will be increased. And as I showed you in the picture, they appear like fire. They appear like a fire, and that definitely tells you there is a tumor or a cancer cell. The other question is, how do you see telling the diagnosis of cancer to patients or family? So disclosure of cancer is very difficult, especially in our setup where the understanding of our society about cancer is very low. When you tell the patient or the family about the diagnosis of their cancer, they took it like a death sentence. So, but one thing that we have to know as a physician, as a health professional, is that patients, they do have the right to know about their disease. And as a health professional, we are required to give a proper information to the patient. So unless and otherwise the patient wants us, you don't have to tell their information to their family. So the priority is for the patient. Unless the patients are unable to they are, for example, very, very weak and unable to withstand the news of cancer diagnosis. So in such kind of patients, there is no point to disclose for the patient. Otherwise, the first priority is for the patient, and you have to learn also the way how to tell or how to break bad news. So breaking bad news is also an independent course, and it needs an art, and it needs also a skill. And probably for the next time, I can present you breaking bad news session so that you can start practicing how to break bad news, including cancer, for patients and their families. Otherwise, not telling the diagnosis for the patient is unacceptable, and it has also a medical legal process nowadays. So we have another question from anonymous attendee. For family history of breast cancer, is getting BRCA1 or 2 gene then recommended, even though there have been some identified risk factors like hormone replacement therapy or fertility drugs? If I understand the question clearly. If the patient is having family history of breast cancer, especially at an early age, it is better if you do BRCA1 test. So for the families, if they have the BRCA1 or 2 test, positive gene mutation, there is also there is a risk of developing breast cancer around 80% of them. Not only breast cancer, but also ovarian cancer. The risk is there around 60 to 80% of the case. So it is better if you do BRCA1 and 2 gene mutation, but unfortunately it is not available in our country. So we just advise and we ask patients historically whether they have family history or not. The other question from one of other attendees that how do you measure the probability of having a baby in cancer patient? General view. So generally, when we diagnose a patient in female, for example, in female patients, most of the cancer we expect to relapse or to recur within the first 2 to 3 years. So we don't recommend patients to have a baby or to be pregnant within these first 2 to 3 years. But after that, the risk of recurrence is decreasing or will decrease. So they can have a baby or they can be pregnant after 3 years. But until then, they have to use non-hormonal contraceptives like IUCD. The other question is something about, say something about cancer of unknown primary. Okay, so there is the diagnosis called cancer of unknown primary or CUP. So cancer of unknown primary means when you examine the patient with history, physical examination, and the available investigation, and if you can't locate the primary origin of the cancer, then you can label the patient cancer of unknown primary. And the histology might be different. For example, it can be adenocarcinoma, it can be squamous cell carcinoma, it can be poorly differentiated carcinoma, but you don't know the exact origin of cancer after having lots of investigation. For example, if the patient is having supraclavicular lymphadenopathy, so you have to have upper GI endoscopy, triple CT scan, and if it is possible, PET scan should be done, tumor markers should be done, and head and neck CT should be done, and so on. So after all this investigation, if you can't look at the origin of the tumor, you can label the patient as having cancer of unknown primary, and the treatment is also different from that of those patients having a known primary, because by definition, cancer of unknown primary is a stage 4 cancer. So the other question is, the patient diagnosed cancer, gastric cancer effectively treatment. I think the question may be, will the gastric cancer be treated effectively? Any cancer with early stages like early stage 1, stage 2 can be treated effectively with curative intent. But once the patient is presented to us with advanced disease like stage 4 disease, there is no place for curative treatment. So most of our patients in our country, they present with the stage 3 and the stage 4, and that's why most of the patients die with cancer. Otherwise, the stage 1, stage 2, and most of the patients with the stage 3, we can cure the patient with proper treatment. In which stage of the cancer surgery is best? Surgery is best usually for patients with the stage 1 and stage 3 patients, because you do surgery just to do R0 or total resection. So the aim of the surgery is total removal of the cancer with without any microscopic residual tumor. So the margins should be negative, and you have to do, if you plan to do the surgery, the microscopic surgery should also be, the microscopic margin should also be negative, and that is usually possible in patients with stage 1 and stage 2 disease. In stage 3 disease, usually surgery is reserved after chemotherapy. When you give chemotherapy, neoadjuvant chemotherapy, usually the cancer shrinks and you can do the surgery afterwards. The other question is disclosing to patient family. I just answered the question above. And the other question is, the next question, how do you manage pain specifically in our country? What anti-pain do you use locally? We use a WHO pain ladder, as I told you. For mild pain, we use paracetamol, ibuprofen, diclofenac, and so on, non-opioid drugs. For moderate pain score, like 4 to 6 score, we use tramadol and other supplement treatments. But for severe pain, more than A7 pain, we use morphine. So morphine is widely available, tramadol is widely available, non-steroidal anti-inflammatory drugs, paracetamol, diclofenac, and so on, they are available. So what you need is to score the pain exactly and to give the pain anti-pain medications according to the score, and you have to follow the response of the patient, so that if the patient is responding, you can continue the treatment. If they are not responding, you have to modify the treatment accordingly. Recommended diet for patients on chemotherapy. Usually the patients on chemotherapy, they are recommended to eat any diet, any healthy diet. You can Google which chemotherapy, which diet is recommended for patients with chemotherapy, with cancer, and who are taking chemotherapy in my website. So any diet, healthy diet, they can take it, but they have to make sure that the diets like raw meat, raw tomato, raw salad, and so on, they have to make sure that they have to avoid such kind of foods, because these patients, they are somewhat immunosuppressed because of the disease and because of the treatment. So that means they are prone for infection. So otherwise, they can take any kind of food, and nutritional treatment is recommended, as I explained earlier, even for the good outcome of patients. How much trust by FNA diagnosis of breast cancer? I explained this one, but FNA, it can tell you it's a diagnosis, the breast cancer, ductal carcinoma, or so on and so on. It can tell you the diagnosis, but in breast cancer patients, what we want is not only the diagnosis of cancer. We want the grade, we want the margin status, we want the lymphovascular, the perinatal status, and most importantly, we want a tissue for hormonal and HER2 diagnosis. So FNA can't give you such kind of information. So it's better, as long as you have the facility, it's better to go for core needle biopsy. And in the base setup in the Western world, the first line investigation for breast cancer is not FNA. It is core needle biopsy with hormonal investigation, HER2 investigation, and so on. So it's not all about the trust. With good pathologists, they can tell you it is a cancer, but.
All right, thank you so much, Doctor, for taking a lot of your time for the presentation and also for answering the questions. So participants, you can check out Dr. Abdu's website. If you want to contact him in any way, you can get his contacts from the website. It is displayed here. So doctor, before you go, if you have any last remarks that you would like to mention, I'll give you the stage.
Okay, thank you very much for having me to this nice session. I'm very pleased to have a contact with a lot of health professionals, like more than 130 participants here. So I'm pleased to be part of this continuous medical education. And for the next session, probably anytime you arrange, if they want any type of any topic in the oncology topic they wanted to be discussed, they can ask the Blue Hills Ethiopia, and you can forward me, and I can prepare myself and I can present in such a way. Or they can also ask like specific malignancies like breast cancer, lung CA, gastric CA, colonic CA to be presented in such a detail. Today, just I presented the whole, just general or the basic approach for all cancer patients, but they can choose any topic from oncology and I can present for next time. Otherwise, I thank you very much, you and the participants as well.